Welcome to everyone. Of course, this is our continuation of the lecture series that we have each semester. And the emphasis this semester is on the continuum of care. But Georgia Studio is also doing a studio study on telehealth. So we have a special presentation today with two speakers. And the subject is on navigating telehealth. And I look forward to hearing that presentation. I'm happy to introduce to you Dr. Deborah Wingler, who is a Vice President of HKS Inc. and is the Health Research Lead in the company. She also holds an adjunct faculty position at the School of Architecture at Clemson University. Dr. Deborah Wingler's research focuses on improving the patient and staff experience through research studies that utilize real-time data collection techniques to elicit insight into patient and staff physiological, psychological, and neural responses to high-stress healthcare environments. Now that's a mouthful, I tell you. Deborah collaborates with the research and design teams at HKS to develop and implement research initiatives that drive innovations and achieve meaningful and measurable impact across the healthcare practices of the firm globally. Both in practice and academia, her research is focused on the integration of research into the design process at varying scales, from development of emerging models of care through multi-year capital projects to development of tools to support evidence-based design decisions and the design of products and platforms to support the delivery of care. Deborah received her PhD from Clemson University in Planning, Design, and the Built Environment. She also holds a Master of Science and Design degree in Healthcare and Healing Environments from Arizona State University and a Bachelor of Science from Northern Arizona University. And she also holds EDAC certification. With Deborah today is Rebecca Barron, Vice President of HKS, and she is in the role of Strategic Master Planning, Ambulatory Solutions, and Portfolio Optimization. Rebecca has extensive experience with system-wide strategic planning that effectively ties vision and performance goals with actionable plans. She's worked with nearly 100 healthcare organizations to help strategize optimum ambulatory locations, patient experiences, and effective operational service delivery. Most recently, Rebecca comes from Common Spirit Health as an executive leader over all non-acute ambulatory strategy and real estate solutions across 22 states and 76 million square feet. She was responsible for aligning strategy, design space models, construction, and occupancy with extremely tight budgets and timelessness and resources related to that. Accustomed to working with executive leaders, Rebecca's specialty is connecting ambulatory solutions with overall service delivery goals, analyzing on and off-campus and real estate options and capital planning. Rebecca holds a Bachelor of Science in Interior Environment from Colorado State University. She's NCIDQ qualified and is a lead accredited professional. Welcome to both of you. We look forward to hearing your presentation.
Thank you, Ron.
Thank you.
With that, I'm going to go ahead and share my screen so we can kind of look at the presentation together. All right, can everybody see the presentation?
Yes.
Great. Thank you again. We are really, really happy to be here with you. So as many of you know, I work really in collaboration, kind of one foot in the health practice and one foot with the research team. And with that, we do both deep dive and applied research. And Becky works with our advisory team. And so what we're going to be sharing with you today is really a collaboration that was done with the health practice, our interiors group, as well as our advisory group, and really zoning in on not just telehealth for the sake of, what is it, but how do we really navigate this in this complex world that we are all living in right now? And not just within the pandemic lens, although we're going to talk a little bit about why that has spurred telehealth on, but also as we look at this across time and what it means moving forward for healthcare and what it means from a strategic as well as a design component. So with that, we're going to go ahead and start going. Let me see. I'm just going to share with you a couple of really key considerations that we're going to cover here in more detail. But as most of you know, telehealth for many, many years has been considered what would be the next big disruptor in the healthcare industry. And telehealth has really been around and making progress. You're going to see for at least 10 years. Could I please ask everyone to mute other than myself and Becky? Could people please mute if you're not speaking?
Those you are the host, you be able to mute.
I don't think I'm a host. Are we good? Okay. Telehealth has been around for quite a while now, and it's actually had been shown to have some substantial impacts in helping to really bring together the continuum of care. And yet what we're going to see, and we're going to talk about today a little bit, is kind of the shift and the change, where it started and where we are today and where we think it'll be heading in the future. Some of the things we're going to be talking about is telehealth as a competitive tool, and that it can be used to gain and secure market share. We're also going to be talking to you a little bit today about balancing the importance of really balancing both your footprint and your cloud print, and how essential that is to really being able to have a full portfolio to work with within your health system. We're also going to talk about experience. And what we've really learned from the work that we've been doing is that experience is more important now than ever as we begin to really start looking at both the delivery of virtual and in-person care. And we're going to talk about the fact that telehealth doesn't necessarily mean less space, and it's because it actually means increased capacity. And we're going to kind of tease that out a little bit for you and what that means. And we're also going to talk about outcomes, right? Because we should really desire to know what these outcomes might be. And what we're going to really talk about is why it's too early to really know what they will be. So it's really important for us before we can take a deep dive into what's really happening now, to really understand where we've been and how we got to where we are. So in 2015, we conducted our initial study on Clinic 20XX, designing for an ever-changing present. And in that, that was in 2015. And if we look back on the timeline in 2015, these are from industry surveys, right? So this is not an HKS survey. This is industry surveys of thousands and thousands of physicians and patients. And in 2015, around 5% of physicians had conducted care through a video visit. And at the same time, about 7% of patients had received care through a video visit. So if we fast forward to the end of 2018, you can see a shift that you've gone from 5% to about 22% of physicians had conducted care through a video visit. And then if we fast forward a little bit to 2019, 32% of patients had received care through a video visit. And then 2020 happened, right? And what's really important to understand is, even though we've been seeing telehealth grow, that even at the point in January of 2020, less than 0.01% of all visits were conducted via telehealth. Hardly any. And yet then with the pandemic, all of a sudden, by April, we saw a spike going from less than 0.01% to almost 70% of visits being conducted in telehealth. This was a rapid shift and a rapid change. And Becky's really going to talk you through what that meant from a strategy perspective, right? It was a huge shift, 0 to 70 in 4 months. And then by July, we saw it really then go from boom to bust, down to 21%. And we have to really understand what's driving that. And then in August, as we were tracking this, we saw it really starting to level out somewhere between 25 to 30%. So what made that shift? What allowed for us to go from 0 to 70%? Well, in March, when the pandemic hit, the Center for Medicaid and Medicare Systems initiated over 80 telehealth waivers and allowances that really fundamentally changed how, who, and when telehealth can be delivered. But it's really also important to note that those were temporary waivers. They were not permanent. And so that bust that you see in July and August, and as it trails out now into where we are today, is because they were temporary. Providers themselves had no guarantee that those waivers that allowed telehealth to blossom the way it did would remain. And much of that had to do with the fact that up until this time, there was no parity of payment for telehealth visits. What that means is a telehealth visit could not be billed at the same rate as an in-person visit. But one of those allowances was that you could charge the same for a video visit as you could now an in-person visit. So you can see that that would have made a really big difference in what physicians felt that they could do. But in August, they released what they proposed for 2021, and you could already see that they were starting to reduce those waivers. One of the waivers that they put in place was that you did not have to conduct a virtual visit on a HIPAA compliant platform. What does that mean? It means that you could use your cell phone and you could actually use FaceTime or Zoom to conduct a video visit. The problem with that is that in order for that to happen, your physician would have said something like this if you were on the other end of the line. Is that all right if we take a Zoom call? Or is it okay if we take a FaceTime call? And you say, of course, it's great. But what most people didn't realize in that is that if you had done that, your data now became part of metadata in a larger system, and it was not protected by HIPAA. And so one of the things that they said that they would do is it would forthcoming in 2021 and after the pandemic would need to be conducted on a HIPAA compliant platform. They also said some visits may have parity of payment, but full parity of payment would most likely not happen. This, along with some other shifts, really started to cause angst with providers as to whether or not long-term telehealth would be feasible. So I'm going to hand this over to Becky to talk to us a little bit about the strategy component of this.
Thanks, Deborah. I always love listening to you talk. She's just so knowledgeable, such a great fountain of knowledge, good partner. So as we think about the overarching picture, it's really clear that the light bulb not only turned on, but has truly energized some focus on 4 key trends that we see continuing to emerge. It's about weaving telehealth in to create expansive and seamless service offerings. It's about integrating telehealth to improve throughput, expand providers' capacities, and it is about ambulatory settings. We do see a significant shift from inpatient to outpatient and the impacts on real estate and how to be nimble and agile, and yet also use data and telehealth to predict and anticipate fluctuating demands for services. So when we say an ecosystem of care, we're talking about the balance between primary care, specialty care, diagnostic and testing across the life of a patient and their family. Telehealth helps connect where physical constraints or gaps can't, such as access to rural areas or resolving long wait times of the now distant past. Shifting to outpatients, number 2, is very important. It's really strong. We've got CMS, who is supporting a huge shift through reimbursements over the next 3 years. And Telehealth can help bridge, if not solve, increasing demands on providers by increasing their capacity to connect and see patients. What we're getting at here is that number 3 is panel sizes, what we call the patient panel sizes. How many patients does a provider see in any given day or a year? They are increasing. There's heavy demand for their time, and telehealth can be an effective tool to help them make connections where appropriate with patients. And a lot of times those telehealth visits are shorter and really applicable in less acute settings where the severity isn't too acute yet, right? And that should allow more in-person time. It must be Friday. Should allow more in-person visit time to address the more complex and acute patient visits. And understanding delayed care, here's what's interesting. That is still unfolding. What I can say about this is this gets into the area of liability, risk. Are we as providers catching everything that needs to be seen with a patient during a virtual visit? Maybe not. But what I can say is that patients are also taking an active role in liability and making sure that they get in to see their doctor or have the right experience according to their own acuity. It's an interesting shift. So we can't say that telehealth is resolving acuity, but it can and should be used to make increased touch points with patients, right? More monitoring opportunities, right? And consistent engagement platform. So this is starting to edge on the competitive landscape, which I spend a lot of time talking to our health systems about. Telehealth has really changed the game, and it is an effective access tool, a scaling tool, and a competitive tool, and it is big business. Even though we see overall visit volume counts plateauing in a certain way, they're settling down a little bit, it's still really big business, and there's no sign of that investment slowing whatsoever. So we know that telehealth doesn't function equally across all the specialties. We'll show you a slide on this. You know, experience to see your cardiologist is very different than maternal or fetal care with expecting moms, or, you know, this is very different. But what I want you to be aware of is that we have an entrance of new competitors. I'm sure you've seen it. Walgreens, CVS, Walmart are now non-industry competitors getting into what we would call on-demand and low-cost virtual care arena. So now patients have convenience, they have options, and that's what telehealth brings. So our larger health systems are challenged with how to meet those demands and yet give meaningful care across the continuum care, quality care. What we will say that we see a big surge in data. Data is the new oil, right? Health systems are scrambling and are becoming very, very savvy in collecting, analyzing, using data on their patients, their virtual portals, on their providers' productivity to really hone in on what's working and what's not. It's not just about having data, it's about being able to use it, analyze it, and relate it to outcomes. That makes sense. Let's go to the next slide. So questions we pose to our health systems and help them think through, at least thought starters. You know, what are key strategic questions around telehealth? And at HKS, we have a lot of data. We've got access to a number of different tools, obviously industry health system case studies with all of our clients, and methodology. And we support the navigation of all of that. So we do start usually with the bigger picture. What's the strategy? And what does telehealth or a virtual platform, what does it do to reevaluate or reposition a particular system or care or service in a market? And by understanding competitors, patients' preferences, capacity pressures, telehealth can help us, you know, help them preserve or maybe even expand a competitive position. And this requires a strong hold on the digital presence, really understanding what a digital front door is. And that's more than just having a website, right? It's about securing loyalty, engaging patients, increasing those touch points we're talking about, and those are all critical to differentiators. For those of you working on projects, think about the digital front door. It's also important to know which services are best suited for telehealth. We'll take a glimpse at that in just a second. It's not a one-size-fits-all, but really about knowing which services and where in the care delivery workflow it makes the biggest impact. That means you got to forecast for increasing pressures, in-person versus virtual visit volumes. We look at a lot of it from a strategic perspective and those volumes, but from space, you know, it's the footprint versus cloud print, understanding which is where, and they're going on in parallel, right? Establishing support education provider for providers. I still hear this every day. Providers are not resistant to telehealth. It's a lot of times it's about the quality of video and quality of experience that they can use their tools and make a meaningful engagement with their patients. What's interesting is we've got retailers, urgent care operators who have come into the arena with really great virtual tools. We talked about payment models. You know, everywhere healthcare is being driven to the lowest cost point of care, and that means telehealth is perceived as pretty cheap. And our systems just need to know what trade-offs are needed to stay in that arena, invest in virtual care, but still provide that quality experience. So for our industry, it's not less space. It is absolutely, in fact, I'm finding that it's about maybe even more space. Let's go to the next slide. When you get to this.
Thank you for talking about that, but I wanted to share with you a little bit about what this really is talking about. And this really, is about what Becky was talking about balancing both the footprint and the cloud print.
Yeah.
And this data that you see here is data that we collected from a survey that we conducted. As I mentioned before, we did Clinic 20XX, our original report in 2015. And when we were getting ready to do our full refresh for 2020, when the pandemic hit. And so in May, in the middle of our telehealth boom, we sent out the same survey to providers. And we added in some questions about telehealth. And so this is what providers said as far as when we asked them what services are best suited to the cloud and what services are best suited to the footprint. And what you see here is that, like Becky was talking about, it's not a one size fits all, and not all services are tele-ready. And what you see clearly here is that for primary care, mental and behavioral health, and some urgent care, that they are very suitable in many regards for telehealth, especially when it comes to follow-up appointments or quick touch bases. But when you look at the other end of the spectrum and you start looking at things like critical care, neurology, cardiology, oncology, and then even some orthopedic, what you start to see is those are not as tele-ready. And we're going to talk a little bit about why. And then you have those that are in the middle, right? And these are the things that really can begin to agilely move between your footprint and your cloud print, truly based upon the needs of your system, as well as based on the external needs. For example, we're in a pandemic. So some more of these can shift when needed, but can come back to the footprint as desired later. The things that we need to be thinking about as we move forward is, what are the changes in technologies that are going to further drive all of these services that you see in the middle, from bariatric, dermatology, pediatric, women's health, oncology, orthopedic, as we get better diagnostics, better wearables, better the ability to exchange more meaningful, accurate data from patient to provider, the more that we will begin to see some of these services moving towards the cloud, right? So there's not just a combination of footprint and cloud print, but it is the technologies that link the two of them that are also going to be incredibly important over the next several years to have that conversation. So let's talk a little bit about experience, right? What is the differentiation between having a virtual experience and an in-person experience? One of the things that we learned from our survey is that providers predominantly still see a virtual visit as a proxy to an in-person visit. So until we begin to truly have parity for the virtual and the in-person experience, that is going to continue. And so let's talk a little bit about where we've made strides in the experience, creating an elevated one, and where maybe there are some challenges across that. These are from some surveys, not our own at HKS, but from some national surveys that were taken during this time of the telehealth boom. And if we just think for a minute and we put ourselves in the journey of a single patient, these are all of the touch points if you're going to engage in virtual care in which you might be touching the system, right? It's everything from awareness and trying to figure out who you would see, how you might see them, doing the search, then scheduling, then actually receiving care. What is your post-care follow-up? Then you have billing. And then we may even start the cycle again if there needs to be another touch point. One of the things that we found is that when it comes to some of that before you even get to your visit, the pre-visit, the awareness, the searching, and the scheduling, that those can really be pain points for patients. And even up to the point of billing. It can either really become a pain point or a joy point, depending on the system that you're working with. As you can see, though, we start to see a lot of satisfaction as we start going through getting into the virtual appointment itself. And then even into maybe even what could potentially be a follow-up, whether that be for finding a specialist, trying to understand what your insurance covers, and also determining where your next appointment needs to be within the system. But then you can also see that then again, it can be very challenging for scheduling or even having technology challenges on the other end. And then really it can go one way or the other as far as follow-up care. Did you get it? Was it appropriate? Did you not receive follow-up care? So these are some of the things that we think about when we think about the patient journey. And this just kind of gives you a little bit more of a deeper dive into where some of those pain points might be, but also where we see that we are tracking doing pretty well. The visit itself, the prep for the visit, the appointment, and then being able to hopefully connect that with billing. Some of the drivers that are really driving patient satisfaction with telehealth, those are convenience, the safety of being in your own home, right? During the pandemic, the ability to not have to be around others in order to receive care has been a real satisfier, but also speed to access, being able to have an appointment quickly when you need it instead of waiting a day, 2, or even weeks, right? But what are some of the drivers of dissatisfaction with patients? The quality of care, not feeling like they're really making a connection, so to speak, with their provider, or even feeling like it's difficult to understand based upon the medium, whether the video itself is not doing well or things like that. Considering that it could feel impersonal, not as close. And that especially resounds with those who are potentially even meeting their provider for the first time virtually. And yet with all of that, when we look at the data across, we see that 96.3 are likely to recommend a video visit. So patient satisfaction is on the rise, obviously, for telehealth. So what does that really mean? It means that when it comes to telehealth specifically, that with people, that connection, we're doing quite well with the experience component. The likelihood of recommending a provider, that the care provider really answers your questions, that you're getting everything done that you needed to in that visit. But when it comes to process, that's where it gets a little bit more difficult and challenging. So as we start to look at space, these are some of the things that we also found out, and Becky's alluded to these, but she's going to take you into a deeper dive of what this means, right, from a spatial component. But in our survey, what we found out was that the majority of providers did feel that telehealth would have some type of an impact on space, but that it wasn't less space, that it was just a change in how that space is designed and the functional needs that it would meet.
Can I add something, Deborah?
Yep.
It's because telehealth visits are additive. They're not just replacement, if that makes sense. So think about parallel realms, in person, right? Footprint and cloud print running in parallel, they're additive.
Exactly. And that's really what we found out, right? In our survey is that the majority of providers felt that telehealth would increase capacity. And it's exactly what Becky's saying. It's that now you can do both a virtual and an in-person visit. And so therefore your panel size can actually grow because of the efficiencies that are created due to that. We also found out in our survey that the majority of physicians selected their clinic office as the space that best supported the ideal telehealth service. However, many of them were using their home office. Call centers from the outpatient perspective were not really used much. Those are a connector within the larger system, and Becky's going to talk to you a little bit more about that. But also really most of them were not doing them in other places in the home, but it was really relegated to the home office.
Love this. So let's get into what it means in terms of telehealth spaces, right? So just the essential components, right? There are a number of spatial and furniture and technology design opportunities that help create an optimum environment for a telehealth visit. And it actually really is important. You can see if we're not making eye contact, or if there's a glare, or if something's going on in the background that is very distracting. And I think we've all learned a lot about how that experience is. So it's important for providers in particular, because we're talking about that side of the seat here, to provide something that's flexible, that has acoustical privacy, sound attenuation. Be careful about the material selection. Lighting should be adjustable, and distraction-free backgrounds that really do help reduce that glare, have a finishing touch and enhance the communication between provider and patient. We also find that it's really important, and you'll see why, that furniture is ergonomic, flexible, adjustable, maximizes the space, right? We see the need for things like large dual monitors and consistent internet connectivity. I've heard a lot about quality of video. Believe it or not, that's still a very big issue. And access to records, right? You want your doc to be able to see your records, and careful placement of the camera. I've got a whole study that has been done on exactly where that camera should be placed. I think you've all figured that out, right? So those are things to consider as we develop spaces specifically for telehealth. So if we go into how these pieces fit together, let's go to the next slide. We're looking at a more traditional clinic module here, but I think it's very, very relevant, because we've been talking earlier with the students and for all of you about, the footprint and cloud print, and what do we do to provide spaces for in-person and then spaces for virtual. And what we're finding is the emergence of the hybrid model. It's really, really important that we understand that our providers are being stretched. And in a perfect world, they would have, and they do say, they're consistently expressing a need to set a block of visits for in-person, separate from the block of visits for virtual visits. However, having the tech connectivity so that in an exam room, you can bring in a specialist. You can bring in a researcher and sign up a patient for a new research program. You can do both and a flexible environment. And so we see providers and their care teams, and I'm going to talk to you about that in a second, but they're being stretched into both parallel realms on any given day. Their preference is to have blocks, because we all know what it's like to jump from one thing to the next every 2 seconds, and it's very distracting and not as productive. As patients, we really want our patients, our providers, to focus on us, right, in our case. And in fact, I got an interesting survey result just this week. 81% of patients are saying that it's extremely or very important that their own provider provide telehealth. Their own provider. So what they're trying to say is, I want access to you any which way is required for my best care, and I want you to understand who I'm about. I want you to have my case, my care folder. I want you to have all my records, everything in front of you. So we see the emergence of these types of offices specifically. It's either the private office, as we've known, or something that we're calling focus rooms that allows kind of a telephone booth type of space that's very private. Shared touchdown rooms that are in the clinic pod, right? So that can support the core team of clinicians or providers to conduct visits that are done virtually and be able to go back and forth to the in-person, and then also within the exam room. So let's dive in one more time, touchdown versus exam. Same principles, really, really important. Whenever we are creating clinics now, we are looking at a solution for something that would be near, I guess that's mine, near pod, near clinic, near flow, to be able to do a private, quiet, right, meaningful experience with a provider patient. Also in the exam room for those reasons that I spoke about. And that's, some of you, especially as students, are really examining what those rooms need to look like. And so I want you to consider these types of qualities, right? Again, the lighting, the layout, the flexibility, adjustability, acoustical attenuation. Think about all of that in that hybrid environment. And then as we go to the next, this gives you kind of a case study of what we see emerging. And I'll tell you, it's really depends on the type of specialty, the system itself. But standardization, modularity, being able to replicate readily is super important. So what you're seeing is in-clinic flow, right? You're seeing on the peripheral of clinic flow. And there is a stronger emergence that we're seeing for third-party spaces or nearby telehubs that aren't too far, not too far, because let's recognize most of our providers are not in a virtual assignment only. They have patients and they need to bring care to those patients either in person or virtually, and bring in those specialists either in person or virtually, depending on the patient's need. So we really are talking about patient-focused, patient-centric care. And I will mention one more thing that we love, and is popping up everywhere. I hope you see lots of them, are tech bars. It's not just, we're not talking about just for providers and education. We're talking about patients, their families. They're getting handed tablets, they're getting handed the remote monitoring equipment, creating those additional virtual digital touch points. So tell me how to do it. And there's the tech bar. There's a whole new career in being a tech bar provider. I'll pause right there.
So what does all of this mean for telehealth moving forward? We're gonna kind of share with you some things that we found out through our survey. So we asked providers what they felt the biggest opportunities were for telehealth moving forward. And as you guessed it, it has not changed since the inception of telehealth, that they still feel that the biggest opportunity for telehealth is increased access to care, right? But in additionally, that element of increased convenience for both providers and patients. But we also need to kind of weigh this, not just with the opportunities, but understand it in respect to the biggest challenges. Because what we see here is that while access may be one of its greatest opportunities, it is also one of its greatest challenges. You know, one of the things that we've learned tremendously, and it's been highlighted more than ever, is that there is a digital divide in this country. And while telehealth has increased access for some, it has not increased access for all. And when we think about digital equity, we need to understand that in many times we think of equity in terms of just low socioeconomic status, but that is not actually true. In terms of digital equity, it has not only impacted those of low socioeconomic status, but it has also impacted those in rural communities, as well as those who are colored and of an older generation. This is a huge amount of individuals in our country who do not have the same access as many others do. And so forward-thinking healthcare organizations are really, really looking, just like Becky said, how are they going to make a dent in digital equity? How will they bring equitable services virtually to their entire patient population? And this is where it comes into understanding what digital equity is about. There are 3 things that have to be considered in digital equity. Yes, you do need broadband. You do need that internet connectivity. You do need the equipment, but that is not enough. It is not just enough to hand someone a tablet or a mobile device and expect them to know what to do with it. They must also have digital literacy. And so forward-thinking healthcare organizations must think in that trifecta and really begin to understand how they can make a difference for their patient population, whether that is providing tech bars or training or touch points along their journey so that they can check in and make sure that they have what they need, whether that be from broadband to the actual tools and things themselves, and the ability to know and be able to use them. Some of the other things, though, that are really important to note that are challenges: reimbursement, right? We heard that straight up, that without parity of payment, they're going to be challenged to be able to make virtual care viable, right? So again, healthcare organizations are really being challenged to think how they can leverage it and how they can use it to really attract and retain their patients as well as their providers, right? But one thing is really important to note. When we had all of those waivers and we allowed for parity of payment, which really facilitated the boom, and when we said, okay, you don't have to be HIPAA compliant, the one thing that we did not change was medical liability. And as we move forward, more and more we're finding that the determinant here is really going to be medical liability. And without changes to medical liability, providers will not be willing to put their license on the line without being able to truly see and feel like they can appropriately diagnose their patients. So again, lots of changes. And this has the ability for telehealth to truly flourish. It is a policy issue. And as our technologies and our providers and our patients go along this journey, the ability for it to really, really flourish is going to come down to what we do with reimbursements, what we do with medical liability, and how we can help people have greater access. Let's talk about outcomes, right? The whole purpose of this is to have better patient outcomes. And yet the truth is, when we took the survey, what we really realized is, yes, everyone does feel like telehealth will have an impact on the quality of health outcomes, but they are very divided on what they feel that impact will be. And it is going to take time for us to truly understand what has happened during this time, the positive things that have occurred, but also some of the challenges that we have with the health outcomes. And it's also going to take us time to understand what we should be measuring and how we should actually be measuring it. And through all of this, what we really learn, and Becky's going to talk you through a little bit of this in the next slide as well, but predicting the future in regards to telehealth is very challenging. We asked providers where they felt the utilization of telehealth would ultimately be short-term, midterm and long term. We are currently in the midterm, right? A year since we started to have our telehealth boom. And the majority of our providers felt that a limited amount of telehealth services would be conducted. And that's really astounding because, as Becky has said, we have health systems that may be in that 0 to 20%, but we have health systems that are doing much more virtual care. And so really beginning to then start to understand, like we had said earlier, how are you going to balance their footprint and the cloud print to truly be able to move telehealth forward and provide providers the really the ability to feel as though it is a viable way for delivering care.
So you can see that we're used to talking to the C-suites of our health system clients. And this is absolutely directed towards CEOs, COOs, CFOs, CNOs, CMOs. But what you can take away today is a few things. Experience matters, right? It's experience of all included, in person and virtual and everything in between. I wanted to share with you a little metric. I'm working with several health systems on how to support the telehealth visit. And it doesn't go away, right? And it's not necessarily one-for-one. I want you to remember that the provider can't take on all the prep and all the post-visit work. Somebody's got to come in and get the visits ready, get them scheduled, make sure that all of the information is ready. Maybe not at the same time, it could be the day before, but an MA might do that, medical assistant. Or on the billing side, or connecting a referral to a specialist, or getting into that research program on a clinical trial. So we've got sometimes a 2 to 3 ratio, 2 to 3 people to 1 virtual visit ratio going on that is requiring some space. Should have said that earlier. So think about the experience, and that's something that's really, really important. And as Deborah was showing us that experience on the front end, if a patient or a provider has a hard time navigating any of our systems across different platforms, it's a problem. So it's got to be seamless, right? So what can we do, right? What can we do to enhance that seamlessness? And how much is too much? There are a couple of things at play here. You've got providers, and demand on care is going through the roof. So being able to carve out non-acute or lower acute from higher acute, the complexity of cases helps, data will help us with that, but using it for meaningful outcomes and to sort that out. Those are really important components to thinking through. I mean, bricks and mortar. I mean, it all comes down to what do you want to do at what place, at what time to support the right people for the right care. That makes sense. And something that I'm going to say it again, competition is fierce. So we came from less than 1% telehealth virtual care up to, right, and then leveling out. Even if it plateaus at 13 to 19 or 20 or 29%, and if we do at HKS, we do know by specialty across all those spectrum of the specialties, what that average is trending. And we got lots of analytics around it, but the bottom line is it's more than zero. It's more than zero, it's huge. So there are billions of dollars being invested to secure market share. We've got competitors penetrating our health systems into their markets that they thought they had loyalty, and they don't necessarily. So got to re-establish their presence. And that's something that we can do with branding and all of those experiential things that we talk about when we create the right facilities and assets, both for virtual and in-person experiences. And we always tell our clients, don't wait for what you don't know. This is a fast running race. You are going to grab that glass of water that cup of water on your marathon, and you're going to keep running. This is not stop here and take a big break. So what we encourage is a lot of scenario building. I've had a chance to work with so many systems through the pandemic, and our whole team has. And this one common theme, the ones who have survived and are moving on to the next and looking for the new norm, is because they built a lot of scenarios. They keep building scenarios. This is not a once a year thing, but it's a bi-weekly thing. so that they can anticipate how to shift services, volumes, resources, people, providers, patients, you know, drive-through testing. Maybe it's now it's a drive-through. We were actually building more drive-throughs, not necessarily for testing or for vaccinations, but for whatever might come, just for giving, to be able to give a different type of care in that arena. So the key word there is building resiliency.
Thank you. So with that, we can open it up. I'll stop sharing my screen. We can open it up for questions. I think we've got about 7 minutes for questions.
We get all passionate about this. Go for it.
Well, if I can jump in for a second and tell you, it's been an amazing day because I'm coming out with more questions than I have had in a long time about a subject, thinking that I knew a little bit by listening to the students and to this presentation. There are so many things to consider on all ends, and this is a very challenging project. So thank you for a wonderful presentation and day.
Thank you. Thank you. Are there any questions that I'm trying to go through the chat, but are there any specific questions that any of you have for Becky or myself?
I have a question. This is Ray.
Hi, Ray.
First, a thank you. Fabulous presentation. Just terrific to hear from y'all. Not surprising. I would expect that from y'all, but it was terrific. Did not disappoint. The question is this. In working with some folks, the center, working with some folks on telemedicine, have encountered a phenomenon, and I wonder if it shows up in any of your data. We work with one physician closer to my age, and their reaction is, well, I love telemedicine. I think it has a lot of potential, but by golly, there comes a time when I've got to palpate that belly. Their words. I want that hands-on. I want to feel it, know it, see it. And then we share that conversation with another practitioner who is considerably younger, who smiles knowingly, patiently waits for me to finish and said, I understand that person is probably your age, right? Said, the fact is, every objection she could raise, we have a way to deal with that with telemedicine. We found a way to make it work. Her reservations are no longer based in reality, they're based in legacy. And so my question to you is, are you encountering generational differences in your data on their perceptions of success, perceptions of futures, perceptions of challenges and opportunities? What are you seeing with respect to age?
That is a great question. So I will answer it kind of from the research end, and then I'll let Becky answer it from kind of the broader what they're seeing there. So from a research perspective, we actually do have that data and we have stratified it. There are two things that depends on. It really does depend on the type of care that you're delivering, number one. And it does, some of it is legacy, but it is truly rooted in this issue of medical liability and licensure being on the line, right? And so if you are a physician and your training has truly been to, I mean, there's definitely a tactile component to care delivery, right? Of just in the diagnosis and all of that. So for many specialties, not all. And so again, it goes back to service, what's most appropriate. And then yes, age-wise, we do see differences. I think even fast forward what that question is, how should we be training our medical professionals that are in school right now to be able to deliver virtual care more effectively? And part of what we see in many of the services, which we showed in that one graph between the footprint and the cloud print, is there are many services that are waiting for the technology to get just enough better so that the data that is coming out of it is true. What I mean by that is many of our wearables actually use algorithms, which means that data is not the raw data. For a physician, you want the raw data. That's what you want. You don't want it passed through an algorithm. So we've got that technology component that as that grows and as that shifts, yes, you're going to see a more rapid adoption. And the question then becomes, what are the competencies that our new providers that are in school needing to have to begin to bridge this chasm between the in-person and virtual care? So that's kind of the nerdy end of it. Becky, you want to take the...
Well, in my past experience, I spent a lot of time with the physician enterprise, and I will defend the age differentiation in that I worked with a system in North Dakota, and the oldest doc was the leader of virtual care and was all about it and totally understood. Well, think about it. I mean, winter in North Dakota makes you get creative about how far you're going to drive somewhere. And so I will defend that much about the availability of the tool, to Deborah's point. So education availability, and that's what we can do within the spaces that we create, is make sure that we are accommodating for the technology that we see today everywhere, and then what we can't necessarily predict. And there's a question, Danielle, about mobility. Okay, so mobile tech, mobile clinics, mobile hubs. It's about mobility of care, if that makes sense. I would say it's not just about the mobility of, so the answer is yes, there's an increase in need for mobile care and everything that it encompasses. So if that means outreach through virtual complemented with mobile clinics, I would say absolutely 100%. There's an increasing demand for that. And for all of us, you've got to think then about the in-person mobility, infection control, mechanical, electrical, plumbing, all of the infrastructure, not just data, all the things that come with mobility of care. Because back to Ray's question, or comment, that there are docs, there are times when you got to get your hands on that patient, right? You just got to get there.
So I love what you said about the mobile, Becky. And I want to kind of also add to that. We have working right now with some very forward clients that I cannot say their name, but they are delivering care to the masses. And one of the things that they've really realized is one of the ways that they can truly make a dent in digital equity is actually taking the ability, creating, let's just say, the opportunity for mobile telehealth visits for the patient. Like think about going into a phone booth, and because you don't have the technology or the internet connectivity in your home, you could get to this place and you could have this virtual visit in this, let's just call it a little virtual phone booth, and be able to receive that virtual care that way. So really, like, thinking creatively of what is even, it really makes you then start to question, well, what is mobile health? What is health care? What is home health now? Like, the lines have gotten really blurry. So you kind of have to start thinking it less of a stratified, like we've always thought about it, and realize that it's really a continuum now, right? From virtual to physical and everything in between.
Thank you so much for answering that question. I specifically am thinking about Carly McCord has also been making comments in the chat. And in spring of 2019, myself and Professor Liu's studio, pre-pandemic, came together to design telehealth booths specifically for mental health visits. And it was fascinating because, you had to ask yourself, okay, when normally with healthcare design, we have control over the whole environment around the patient. Now we only have control over this box here. And, how can we benefit this patient in the best way, make them feel comfortable? And so that was really fascinating looking at that spring of 2019. And here we are. So it's upon us.
It is upon us in a very big way.
And behavioral health and psych is one of the home runs in telehealth. We're working with another system who has a whole new center of excellence being built. And all of the elements that we're talking about include in terms of telehealth, and they are looking at volumes tenfold what they were planning at the beginning of 2020 that they can now accommodate within that same facility.
Wow.
I've got a question for you. Oops.
Sure.
We
Go ahead.
ready? Yeah, this bill, and Ray knows my question, so feel free to correct it. I'm curious about when will Apple Health and artificial intelligence be the principal drivers of primary care?
Right. So, Becky, go ahead. I'll let you field this one first.
Well, you know, you're asking about the crystal ball. And I think you're getting at the rumor that there's a point where AI is going to take over the place of the provider, the physician. Is that where you're getting at?
Well, just the primary care.
Okay, well, primary care. Well,
Fast enough. We can't, you know.
yeah, we still see primary care as the fundamental seed. The primary care provider is always going to be the front line, if you will. What we see happening with AI in particular and in big data is being able to leverage that practitioner's time. Primary care, if they could use some predictive analytics, if they could use some symptom analysis so that they are looking at, you know, 50 calls that came in from patients today and reduce that time so that there's a computer, something smart that said, well, you know what, this could be happening. Look at these particular types of, potential prognosis and see, now talk to your patient and really expedite that preparation, the research that primary cares have to do. And then of course, connection with specialists, being able to refer out and bring in smart minds. We do not see it as anything more than making their world easier.
Yeah.
They're certainly not going away. There's a huge shortage for primary care practitioners.
Yeah, absolutely.
And I was going to say, we see it much more. I was going to say, we see it much more as something that can really help with the healthcare workforce shortage and really help to expand the healthcare workforce that we do have in a more meaningful way.
There's the point.
I think this has been extremely gratifying to me because it's the day, the morning session followed by your talk. You've come up with more thoughts for me and questions as we move ahead on this research and design practice-based studio. And for the students, I think you see the importance of working with researchers who can reframe the basic question that we as architects often go and knock something out similar to what we've done before. Because the basic questions, I think, came across, and the students who are going to go on to the next phase of the project, you've got your work cut out for you. And it seems to me that we've got to look at a lot more angles than we were in terms of the patient journey and the physician's journey and how they come together with technology. So kudos to you for leading the way. I think, and let's take another question. Maybe I took too much time here from the students or visitors or any observation that you may have. The comments, you've gotten a lot of good comments from the students. So you may want to look at those before you leave the chat. Anybody else?
George,
Yeah.
George, this is
Professor
Fred.
Mann?
Go ahead, Joe.
Oh, I didn't know if I was interrupting. I do have one quick question. Deborah and Becky, you've done an outstanding job, and I certainly am impressed with all your work at HKS. If you go from the drivers and the spaces and some of the systems impact and drivers for design, would you, Deborah or Becky, talk briefly about, say, the top 3 architectural challenges, similar to Professor Mann's comment about how we could say, well, telemedicine challenges the architects primarily in 2 or 3 different ways.
I want to make sure I understand. I want to make sure I answer this appropriately. So what I think I hear you asking is, as an architect, what are some of the things to really focus on as far as when you think of integrating telehealth into a space?
Right.
Yeah. I think, first of all, really having that fundamental understanding that it's not about the application of technology anymore. It is truly about the integration of technology into that space. So thinking of things, when you think back to what Becky was talking about and talking about how is this component now integrated into the flow of a visit, right? How does it get integrated into their work day, into their practice, into all of these things? So that's one part of integration. But the other part of integration is, how do you begin to make this seamless? It goes back to when I talked about how can we make it so that it is no longer a proxy, that virtual care, a telehealth visit, is no longer a proxy for an in-person visit, right? So really beginning to look at how we can start to create much more of a seamless connection between both the virtual and in-person realm. So I think that's kind of the second thing that I would add. Becky, is there anything else between those that come top of mind for you?
Well, just real quick to keep it simple is I wouldn't overthink the layer of these crafty spaces, because I think the fundamental principles of flexible modular design, if you stick with those principles, then what you'll find is, and this is what we found with, I'm just going to go back to our case studies with all of our clients, because we've had projects on the books, projects under construction. And the question really is, what did we have to change, right? So it wasn't necessarily about changing the overall clinic module or those pods, but it was about the ones that had been built with modularity in mind, right? Then it's about repurposing and hopefully not too much technology, but there's a lot of conversation about more drops, tech drops. But if you think of it in terms of what is it today, who's it serving today, and in that same footprint with those little boxes, right? Can that same layout then be something different, right? As it's built. If you keep those principles in mind, those projects that were on the boards, under construction, we have not had to stop. There was a pause for some of them for capital planning, for cash, but we haven't had to stop any of those because they were well designed. And some of the largest, most mature systems in the country, I was going to say, some of them have, the brilliant design that they've invested in, and it's been very resilient, and it will carry forward into perpetuum. But it's not always a matter of being big and mature, because we've got some really small health systems that are just brilliant. And there's a question in here about on stage, off stage, that whole care flow. And absolutely, there's an absolute driver towards experience. What is the right on-stage experience, patient-facing spaces, and behind the scenes for non-patient facing spaces? I think this has really driven that home, but mostly that is effective and in principle and gaining momentum, because it's about flex principles. It's really about the fundamentals. I hope I'm trying to wave my hands and make sure that it's clear, but I'm not sure if it is.
What I'd like to do is I could go on for hours.
Right.
Respect your time. To the students, being able to speak. These are two people who are extremely articulate and are able to express themselves very clearly in words. And architects often don't have the opportunity. I think the first year students talk more than the graduate students, who start grunting in short words, but by being exposed to speaking, it's very important. I'm not the best speaker in the world, but we had two of the best speakers here. And so think about why you're being asked constantly to talk to people and present, so that it gets to be as even as possible. With
George,
that, yes.
George, just a very short comment, please.
Go ahead.
I'm just demonstrating my incredibly firm grasp of the obvious. For the students who are here, what you saw today was what everybody in our program is constantly preaching, the power of research to drive design. Can you imagine any of these conversations with any of the HKS clients happening without the ability to back up their suggestions, their insights, their recommendations, without that research? The power of research to drive design. It's evidence-based design. It's a powerful concept. You're at one of the great places in the academic landscape to study how research impacts design. And what you heard today was how that unfolds in day-to-day real professional practice. It is where architecture is going without question. And you're in a great place to take advantage of those developments. So don't miss out.
Well, I'm glad you said that. It was well expressed. I also would like to recognize Eric Baker, who works with Larry Zuber. And Eric, you're welcome. You could see we've got some heavy hitters here, and the entire issue of research has to be further defined. And I personally think it needs to be integrated into a research and design studio that's practice-based. So, but not everybody feels that way, maybe in time. On your syllabuses, you've got Maya Kyle's excellent report to look at. It's an opportunity to express yourself clearly and professionally. The students have worked very hard. This has been a great day. I also would like to ask Luis, excuse me for not joining Shay. My son's last supper was here last night after a stay since before Christmas that encompassed COVID for 3 of them. And they left, so I couldn't come. I hope you can share the Innova group with all the students, because I wasn't there, but I know it's something they want to hear. So anything you want to add to that?
Yes, we have that recording. So yesterday, the Innova group gave a presentation on virtual etiquette for the upcoming career fair that'll be happening next week. So we have that recording. That had a lot of good, insightful information. And so if anyone's interested, please email shaytamu@gmail.com, or I'll send it to your students, Georgia. If you can give me a list of their emails, and I'll send it to all of them.
Or you can send it to me. It'd be less work
Yeah.
for you. I've got it and I can forward it.
Definitely.
Are there any other announcements by faculty or students about interesting things going on?
Excuse me, George, one moment. I just wanted to let everyone know that I went ahead and put a link in the chat. And it is a link to the full Clinic 20XX telehealth report. This is the provider results. We are in the middle of compiling the patient results.
Right.
And so we'll let you know as soon as that report is out as well. But in case anybody wanted to read the full report, we shared some of it with you today, but you can read more in detail.
Can we access a chat after a session? Will it be on the recording, or does anybody know?
It's on the recording, George.
Save it.
All right.
You can click on the.
You see
3
how much
dots.
you know? I know very little. And well, Madison, you want to flash up next week's lecturer? Okay. Joe, are you still here? You were instrumental in getting Deborah here. Okay. I don't know if you can see this.
Yes, I can see it. Yeah, I'm anxious to see what Deborah has to say. The Center for Design there is doing some interesting work, and I hope that people become aware of what they do and how they affect the built environment. So I'm anxious to hear what she has to say.
And you know, this health field is so broad, and I'd like to think that I know Deborah, but I've just never invited her here. She may have been here. I don't recall. She's a heavy hitter in her own right. So we're glad to have her next week. And now you can click on that blue to go right to the lecture series. You don't have to do that now. Ron, do you have anything you want to wrap up or say?
Can you hear me?
Yes.
I just want to say that this has been one of the best presentations I've heard, and I agree with what Ray said. Good design comes from good research. I remember coming from the CRS background that you have to define the problem before you can design it, and research is a big part of that. So thank you so much for the presentation that we received today, ladies.
Thank you for the opportunity. Truly a pleasure and a privilege to be with you all today.
Absolutely.
And
Thank you
Brian,
for the
do
opportunity.
you want to say anything? And
Thanks and gig 'em.
yeah.
That's right.
Hey, students, enjoy your respite. I'll see you bright-eyed and bushy-tailed on Wednesday.